Hi, good evening, friends. Today we are going to discuss about what are the anesthetic considerations in laser surgery. Before going to the anesthetic considerations, let us discuss what is a laser, how it produced, and what it affects on the tissue damage whenever it was exposed by this laser mission on the tissues. Okay, so laser, coming to the history, Theodore Mannheim created the first laser in 1960 by using an electrical source to energize a solid ruby. And the first medical application is reported by the Leon Goldman, an American dermatologist, in 1962. So laser means light amplification by stimulated emission of radiation. It's a device that stimulates the atoms to emit light at a particular wavelength and amplifies that light and producing a very narrow beam of radiation covering an extremely limited range of visible infrared or ultraviolet wavelengths. The laser provides a source of focused current light capable of transmitting intense energy to a precise location. So it transmitted the intense energy to a precise location in the form of coherent light. Okay, this is the physical principle of laser. The electrical energy will be there. It will stimulate the media. The medium will generate stimulates atoms, and it will stimulate the beam. That beam will be delivered as a laser beam. So this is entirely process laser medium. This is a laser medium. It should be excited by the electrical resources. Two reflect mirrors will be there. This excitation increase the number of atoms and progression to the stimulated emission of. So you can see emission of and release of excited photons spontaneously in all directions. Then all this mixed and they form a small subset of these photons travel along the center line to form a beam, laser beam, and generate the final product. So coming to what is the difference between the laser light and ordinary light? Laser light is a monochromatic, ordinary light is a polychromatic. It consists of photons very narrow band of wavelength, in wide spectrum of wavelength, and it is a coherent electromagnetic field of all photons oscillate synchronously in identical phase, but in electromagnetic field phase randomly here. And beams are collimated here, so minimal dispersion parallel, but spread out in all directions at a point from the point of source in an ordinary light. So what are the effects of laser on tissues? So what are the laser factors that will affect the laser on tissues? What are the tissue factors that will affect the laser on tissues? So laser factors depends upon the wavelength, depends upon the power, depends upon the intensity, depends upon duration. The effect of the laser will be there on the tissues. Regarding tissue factors, regarding depending on the absorption, depending on the thermal conductivity of the tissue, depending on the local circulation, and scattered things. These are all the tissue factors that will affect the effects of laser on tissues. So what happens when the tissue exposure laser? The four things will occur. One is reflection, absorption, transmission, scattered. So reflection, and the angle of reflection is equal to the angle of coming out. That's called reflection. So these are all these four things that will happen. So finally, the laser tissue interaction will be the most surgical lasers produce thermal effect at the tissue level by the laser tissue interaction to cut and coagulate and vaporize the ablated tissues. And some mechanical factors also will be there through the laser. It disrupt the tissues by the producing sonic energy, acoustic energy, like the breaking apart of kidney stones in the ureter. And chemical effect also will be there through the laser to activate the light sensitive medications to disrupt and change the tissues. So what happens? The tissue changes temperature. So different temperatures, the tissue will react differently. So absorption of laser energy excites atoms within the tissue and produces heat. The CO2 laser heats the water within the cells. At the temperature of 65 degrees centigrade, the proteins denature and thermal necrosis will occur. At the rate of 100 degrees centigrade, the water within the cell vaporizes and cell exports. You can see the different tissues. So first is hyperthermia, and reversible change occur less than 50 degrees, and irreversible change occur more than 50 degrees centigrade, and tissue will be vaporized more than 100 degrees centigrade. So 37 to 60 degrees centigrade, no visual change will occur. The biological change, warming and welding, and 60 to 65 blanching will occur, and coagulation will occur, and 35 to 90 degrees white and gray will be, you can see the visual change, and protein will be denatured. 90 to 100 degrees, you can see the puckering here and drying of the tissue, biological change will occur, and 100 degrees centigrade smoke plumes and vaporization of the tissue will be occur. So main thing is it will increase the temperature here, and different temperatures, the tissue reactions will be present. So what are the indications of laser surgery? Airway surgery, dermatological surgery, thoracic surgery, gynecology, ophthalmology, plastic surgery, neurosurgery, ENT, neurosurgery. These are all the different surgical conditions, surgical and medical conditions where we can use the laser regularly. In airway surgery, to remove the benign growths like nodular polyposis and granulomas and vocal cord dysfunction sometimes and malignant growth and recurrent respiratory papillomatosis is the different conditions. So what is the advantage of laser? So it acts as a scalpel and electrocoagulator laser. With excellent surgical precision will be there, and preservation of normal tissue will be there, unaffected side, and good hemostasis we can do, and rapid healing will be there, and less scar formation, lower infection rate, and less postoperative edema and pain, especially useful for airway surgeries, less post-op edema and pain. So laser classification kind of American National Standards of Institute. It is on the international standards of International Electrotechnical Commission. They divide the laser into four class: class one, class two, class three, and class four. Class four are the most medical laser belong to the class and pose the dangers to the eye and skins. So most medical laser belong to the class four and pose dangers to the eye and skin and combustible material. They are fire risk producer contaminants and plumes. So all class 3B and class 4 lasers must be operated by a trained authorized personnel and equipped with a key switch and a safety interlock. Different medical laser scissors, CO2 laser, NDR laser, KTP laser, argon laser. And you can see the different things and different waveforms, different absorb things and tissue penetration, which is a more high tissue penetration compared to argon laser. It is the highest tissue penetration 2 to 5 millimeter. Depending upon the pathological condition, they will use the different types of lasers. So laser hazards are atmospheric contamination by the laser plumes and misdirection of laser, it causes the damage to other tissues, and sometimes gas embolism will occur, and the energy transfer to the inappropriate location also causes. Sometimes fire will also cause. So laser hazards and laser plumes. Laser is used during the treatment of vaporize and coagulation cut the tissue. The vapors and smoke and particular debris produced during procedures are called laser plumes. Laser plumes means the vapor and smoke and particular debris produced during this procedure are called laser plumes. So these laser plumes may contain biogenic carcinogens and mutagens and irritants and fine dust, bioaerosols and viruses and cancer cell and blood fragments and bacteria spores depending upon the type of the procedure. And chemical things may be carbon monoxide and polyaromatic hydrocarbons, various toxic gases, formaldehyde and hydrogen cyanide, actylene, benzene. These are all things also contained, also present in the laser fumes. So what are the different laser fumes, different dusts that will present? This slide will show. So I am skipping because this is not important for answer conditions. So these are the different laser fumes that will cause interstitial pneumonia and bronchiolitis, and they will cause the reduced mucociliary clearance and inflammation. So how can the plume can be controlled? This is very important. So plume can be controlled by the ventilation and safe work practices and personal protective equipment. So ventilation, two types of local exhaust ventilation: a mechanical smoke evacuate system with a high efficiency particulate air thing, and second thing is an ultra penetration alpha filters and HEPA filters should be used to capture the fumes. Each smoke evacuator should have the capability to detect if a filter is getting overloaded. HEPA filters and alpha filters. And safe work practices like there should be laser safety program in place. All staff of this of the laser unit should receive training in the safe use of equipment, how to keep the equipment in a good working order, and education about the possible health and safety hazards. And personal protective equipment like appropriate respirator should be used. This respirator should be used to provide the additional protection. It's not a substitute for air exhaust system, but it gives a personal protection. So surgical masks do not eliminate the risk of infection or other hazards from inhaling, and gloves and eye protection. These are all personal protective equipment. So these are all the different colors of glasses. We use the different color of. If you use the NDR laser, you have to the green filters. If you use the ruby lasers, you can use the blue filters. If you are in the red purpose, engineering purpose, if you have the KTP argon lasers, you can use the amber color argon, and clear glasses and plastic goggles will be used for the CO2 laser. These are all different colors of the goggles used for the different colors of the different types of the lasers. So laser hazards are misdirection of laser energy may lead to the perforation of viscous and large blood vessels, and laser-induced pneumothorax may be the complication. So gas embolism, one of the other complication from the laser. So venous gas embolism during the laparoscopic and histoscopic laser may occur, and it also reported that NDAG laser resection causes tracheal and bronchial tumors. Other laser hazards are so energy transfer to an appropriate location. The tissue damage outside the surgical field that will damage us and it drape the fiber, and sometimes endothelial tube may fiber, and eye damage will occur, like corneal retinal damage will occur, and skin damage also occur from erythema to blister or charring. And fire explosions is if severe, if you don't take precautions early, it may lead to the fire explosion, fire and explosion also. Whenever the laser contact inflammable material such as rubber or plastic, it may cause a fire and explosion. So these are all the triangle, airway fire triangle, incidence 0.5 to 1.5. What are the predisposing factor? Ignition source is one of thing, and drapes and preparation agents and heated tubes and oxidizers. So these are how to prevent the air fire and how to approach the air fire. So if the limit ignition source, you have to limit the laser intensity duration and short repeated bursts, that is pulses type. So not in a prolonged continuous, instead of prolonged continuous exposure, short repeated bursts, pulse type, that will decrease the fire, and decrease the FiO2 will decrease the fire. And do not use the nitrous oxide. Instead of nitrous oxide, nitrogen and helium can be used. That will decrease the fire at the operation site. And if possibly avoid the intubation and use the laser if impossible to use the laser resistant endotracheal tubes, and the surgical drapes made of flame resistant waterproof material allow the sufficient time to dry the preparation solution. Sometimes the spirit solution, like the solution, should not allow though, that will catch the fire. These are all the different things so that we can avoid the fire. So blowtorch like fire in the heated tube, it is not visible visually. So in any airway of fire is a life-threatening complication, but the blowtorch fire is especially feared complication. So nobody want to see these type of complications. When the laser strikes unprotected external surface of endotracheal tube, so local thermal destruction will occur. It remains unrecognized and burns to the interior of the tube, and combined with the oxygen enriched gas, then it causes the blowtorch like fire, which rapidly spreads to the proximal and distal areas. So what are the anesthesiologists should be aware of? Surgical procedure and has to patient comorbidities and hazards of laser to exposure of the patient. From here onward, there are all the anesthetic considerations. These are all the introduction. So that's why the anesthesiologist considerations are, so you should be aware of the surgical procedure and patient's comorbidities and hazards of laser exposure to patient and OT personal equipment, and physical properties of laser medium also should be known by the anesthesiologist, and vital structure around the point of focus and how to protect the vital structure also anesthesia should be minded. So which technique of anesthesia you can use? So upper this one article published is the upper airway management guide provided for laser surgeries. So they conclude that we have no means of abolishing the risk of an airway fire during the laser use, but there are some risk reducing methods of airway management are available. That is a non-intubation techniques, that intermittent apnea technique, spontaneous breathing and jet ventilation, and intubation techniques. So intubation to conventional tubes, conventional tube with protections, and ready to use and laser resistant tube. If you use this non-intubation, or if intubation is how to intubate, then you have to use conventional tubes and ready to use a laser resistant tube so that we can reduce the complications. So intermittent apnea, patient is intubated and extubated intermittently with the airway exposed using the suspicion of laryngoscopy. So endotracheal tube removed to allow for a period of apnea and laser application. The duration is guided by the SpO2 and enteric carbon dioxide. So we have to monitor the SpO2 and enteric carbon dioxide regularly. The period of apnea only allowed is only up to the 5 minutes we will allowed. The SpO2 should be more than 90%, and EtCO2 means 40 to 60 mm of Hg. So addition of continuous respiratory gas delivery via high flow nasal cannula may further increase the apneic period. And TY is to maintain the anesthesia in these intermittent apnea techniques. So you have to maintain the SpO2 more than 90% and EtCO2 40 to 60 mm of Hg. If possible, you can use the apneic method of oxygenation. Spontaneous breathing patient is anesthetized maintaining on spontaneous ventilation, and an oxygen enriched gas is delivered through a side port of the operating laryngoscope or a catheter. So inhalation anesthetic are best avoided since these will invariably escape into the OR environment. So ventilation cannot be assisted here. The patient should be on a spontaneous ventilation, and we cannot use the muzzle relaxants here. Just to keep that like TIVA, can you keep the patient in a spontaneous breathing. Third thing, jet ventilation. It utilizes high pressure stream of gas that is delivered to the upper airway. So an injector connected to the gas supply insufflates the respiratory mixture into the trachea, but the removal of gas depends on the passive exhalation and requires a patent upper airway. So we should maintain the patent upper airway for exhalation. So any small diameter of the upper airway stenosis that impairs inflow and outflow of gas, it creates a risk of air traffic, especially in the lung. So high frequency jet ventilation delivers very small amount of tidal volumes at very high respiratory rates. So a specialized equipment is needed for the jet ventilation, and properly trained person must be needed. And then a TIVA technique and blood gas monitoring are also needed for this jet ventilation technique. So these are all the three techniques of ventilation. So non-intubation techniques, what are the advantages? So intermittent operatic advantages are excellent visibility and less trauma. Disadvantage, inadequate ventilation you can see, and the risk of aspiration will be there. If spontaneous breathing, vocal cord function can be evaluated, and excellent visibility is there. And good for compromised airway, especially spontaneous breathing advantage. But the disadvantage spontaneous breathing are aspiration risk is there. Sometimes hypoventilation will occur due to hypoxia, and depth of anesthesia is inadequate in a spontaneous breathing. So jet ventilation advantage, a less risk of airway fire and better visibility and less trauma will be there. And disadvantage that it is difficult to control ventilation and more risk of aspiration will be there. Inability to use anesthesia gases. Sometimes bowel trauma will occur during using the jet ventilation. So intubation techniques, advantage are the secured airway should be there, and intubation techniques, the less risk of aspiration will occur, and controlled ventilation will be there. We can administer anesthesia gases, and we can monitor the ETCO2 through the intubation techniques. What are the disadvantages? ET tube may obstruct the surgical view, and sometimes airway trauma will occur, and more risk of airway fire will be there for the intubation techniques. So conventional tubes are red rubber and silicon tubes, so they combust more easily than the PVC tubes. Red rubber is more resistant to puncture and ignition by the CO2 laser than the PVC. If ignited, the PVC will be soft and deform, and the silicon tubes become brittle ash and that crumble easily and separate and lead to retention of segments within the airway and be aspirated. The silicon tubes they will become a brittle ash, and they will attach there itself. So red rubber tubes, they tend to maintain their structural integrity if they ignited. So conventional tubes, what are the advantages? Do not reflect the laser light, so avoid the injury to the non-target tissue. And this conventional tube, they do not retain and transfer of it to adjacent tissues. These conventional tubes, they meet standard specifications for the cuffed and uncuffed tracheal tube as outlined by ASTM F1421242. The PVC tubes are transparent, so condensation of airway vapor and evidence of combustion can be seen within the lumens. What are the disadvantages of conventional tubes are they readily ignite and maintain the combustion in the presence of oxidizing atmospheres. In the event of such fire, the tube integrity may be compromised, allowing the components to be retained within the tracheal cavity, tracheobronchial, especially in the PVC tube. So conventional tubes can produce the products of combustion which are toxic to the human tissues. So these are all the conventional tubes with protection. So we can use some protection by wrapping on the conventional tubes. So standard tracheal tubes are red rubber tubes and silicon tubes or PVC tubes. So they will be wrapped with a laser resistant material, but cuff should not be wrapped here. So cuff will be exposed. That is a disadvantage here. So conventional tube with protection. So the wrapped material may be the aluminum and copper foil tape with the adhesive back will be there, and Marcel laser guard, the Marcel wrap will be there. Marcel wrap or aluminum copper foil, they will wrap the conventional tubes. So how to wrap the tube? Put the tube with a medical adhesive. They will medical adhesive like benzoin. They will pull and cut end off the tape with a scalpel at a 60 degrees angle. So this is a 60 degree angle they will cut degree and start the wrap from the junction of the tube and the proximal end of the cuff. The junction of the tube and this is the proximal end of the cuff. From here you have to start the wrapping. So wrap in a spiral with 30 to 50% overlap the area. So this is the first wrap. Second wrap should be overlap the 30 to 50% of the first wrap. So wrapping includes inflation tube of the cuff sometimes. So what are the advantages of wrapping? Metallic wrapping may prevent the laser beam from igniting the tube but still allow use of conventional tracheal tubes. This metallic backed surgical sponge has been designed specifically for use of any airway laser operation. The disadvantage of wrapping is no cuff protection will be there, and it will add the thickness of the tube. The thickness of the tube will be changed. So it's not an FDA approved device and may reflect the laser beam to non-target tissues, and protection varies with the type of metal foil they will use, and sometimes they will cause airway obstruction, and rough edges may cause damage to the mucosal surfaces. So wrapping. So ready to use the laser resistant tubes. So these are all the commercially available product designed for the use of during laser surgery on the upper airway. So many of these products have a inflammable component that can be ignite if manufacturer warnings and precaution direction for use are not followed. If you're not followed, they will ignite. They have several disadvantages, but they are bulkier, they are stiffer, and sometimes mucosal abrasion like a traumatic and reflects the laser beam and transfer heat, and moreover they are very expensive. So laser flex tubes, milling trot laser tubes. So airtight stainless steel corrugated spiral tubes with the PVC Murphy will be there. Here you can see the double cuffs. Double cuffs will be there. Uncuffed version for the pediatric. This is a pediatric use for uncuffed version. For adult, they will use the double cuffs. That is the laser flex tube. So laser flux tube advantages are, so metal components are non-inflammable. The tube maintains its shape during the intubation and kink resistance. The proximal cuff serves as a shield for the distal cuff. Distal cuff is the proximal broken also distal will maintain the tracheal cuff. Disadvantage, metal may reflect the laser onto the non-targeted tissues and result in damage. The cuffed part is flammable and need to be inflated with a saline to decrease the risk of ignition. Double cuff takes more time to inflate and deflate than a single cuff. So metal may transfer the heat to the adjacent tissues and other materials, and metal tubes are thick walled. So laser shield tubes, Zomed laser shield tubes. These are all the silicon tubes. Inner aluminum wrap will be there. Inside the aluminum wrap will be there. Outer Teflon coating will be there. It is intended to use the CO2 and KTP lasers. So laser shield advantages are the wrapping prevent the laser beam from igniting the tube but still allow the use of conventional tube. And the Teflon coating is smoother and less traumatic. The methylene blue in the pilot balloon will mix the normal saline and provide a marker for the cuff perforation. So it is preamble and quality checked by the manufacturer. And disadvantage of laser shield too, if the tape is dislodged, it can occlude the airway. So tubes cannot be wrapped on or below the cuff. So this area remains exposed and vulnerable to laser. And comfort to no advantage when the site of operation distal to the tube, the laser beam is delivered through the lumen of the tube. So combustion and pyrolysis of Teflon yields toxic fluorinated byproduct at the site area. So bioma foam or cuff laser tubes, they are the different cups. This is a aluminum silicon rubber spiral tube with a silicon covering will be there. Here with a unique inflating foam sponge filled cuff which prevent the deflation after puncture. This foam will be there. It will prevent the deflation after puncture also. So what are the advantages? This atraumatic external surface is a non-inflammable inner surface. Cuff remains sealed despite of the penetration by the laser. Disadvantages are this flammable external surface and cuff. It may be difficult and time consuming to deflate the cuff if the cuff or inflation tube is damaged. So Norton tubes are, there are spiral wound metal tubes. They are reusable, stainless steel connector will be there here, flexible tubes and no cuff, and they are very thick tubes. So protection of the cuff. So fill the cuff with the saline. If you use the cuff tubes, you have to fill the cuff with the saline, colored with the biological dye, the methylene blue in case of single cuff. In case of dual cuff, distal cuff is filled with the saline. The proximal cuff is cuff with the dye. So if you proximal cuff ruptures the dye, you can see the dye so that you can assess which cuff is rupture, perforated. And place the cuff distally in the trachea and cover the visible cuff with a moist and cotton platelets. So this will decrease the risk of ignition, serve as an indicator of cuff rupture if such occurs. So before doing the procedure, before doing the laser procedure, we have to see that the OT should have the proper signages. The signage should be there so that nobody will enter into the operation theater. So caution will be there, laser radiation, so do not enter into it. So all personnel involved should have the proper personal protection equipment when they are present in the operation theater during the laser surgery. So choose the appropriate technique and device as per the resources. The smallest acceptable endotracheal tube is chosen to maximize the exposure of the surgical field. Cuff is filled with a normal saline mixed with a biological dye like methylene blue, and you have to minimize the FiO2 to the smallest required concentration, and avoid the using of nitrous oxide, and keep a spare endotracheal tube, preferably smaller size. So what is the protocol management of the airway fire? Four E's are mnemonics. So first is you have to elimination. So stop the ventilation if the fire, you are suspecting the fire, and turn off the oxygen, and extraction, disconnect the circuit and remove the endotracheal tube. Okay, then you have to extinguish. So if the fire persists, the flood the surgical field with saline, and you have to evaluation, and then you have to assess the airway damage. These are all the four E's that you have to maintain whenever the airway fire occurs and airway fires occurs. Four is elimination, extraction, extinguish, and evaluation. So the management of fire. So management of fire, remove the source. First you stop the laser and remove of the fuel source. Immediately you have to remove of the endotracheal tube, other burning fragments, and eliminate the oxidizer fire. Disconnect the tube and stop the ventilation and stop the delivery of gases so that you can protect. So management of air fire, extinguish the remaining fire if any with water or saline, and continue anesthesia by intravenous route, and make ventilate with 100% FiO2, and perform directed video laryngoscopy, bronchoscopy to assess the damage and remove the debris, and bronchial lavage may be needed sometimes to wash out the fragments, and we have to re-establish the airway, and that means of re-intubation, and place a laryngeal mask airway, and assess for the damage of oropharynx and face. So we have to take care of the situation, and we have to re-establish the airway, and we have to assess the damage of the oropharynx. So conclusions. So laser surgery is a nightmare for anesthesiologists. So the anesthetist should maintain adequate depth of anesthesia, and he has to maintain the immobile field, and he has to selection of non-inflammatory so while for intubation, and he has to maintain the adequate oxygenation and ventilation also. And if some fire occurs, he has to take some precautions to prevention of airway fire and explosion, and good post-op care, watch for the laryngospasm, laryngeal edema in post-operatively after surgery is over, and immediate treatment of airway leaks at the end of treatment, and scavenging of OT gas and laser fumes, we should be careful. So these are all the different things, the different conditions how to taking care of anesthetist. Okay, thank you. Conclusion, thorough preoperative evaluation, mutual planning with the surgery is there. Proper protective safety measures should be undertaken both for the patient and OT personnel with regard to the laser exposed to eyes and skin, for the exposure laser fumes and airway fire and other fire hazards. And you have to use the proper anesthesia technique depending upon the locally available resources and the skills and helps. So be alert for detecting the early signs of airway fire. If the airway fire occurs, you have to manage the airway fire. So anesthesia role is also very important during the laser surgery. Surgeon will concentrate on surgery, but anesthesia has to see the entire surgical field and out of the surgical field also to prevent the hazards in a hazards during the surgery by using the lasers. Thank you.